Doctors, we are live. You can start the session.
Good morning, friends, and welcome to this season 3, episode 7. This is our signature tune. So, brain teaser is just not an education, it is also an education to learn while you are playing. You have a lot of time to play. So once more, good morning, friends, and welcome to this 7th episode of Brain Teasers in this season 3, in this month of March, which also happens to be the first month of spring. Well, do you know, March is derived from the word Martius, which signifies the first month of Roman calendar and is named after Roman god of war. March is also the time of a year when animals start waking up from their hibernation. Well, friends, we as an ophthalmologist also need to wake up to the call of this blinding disease, which is celebrated this month, and that is glaucoma. World Glaucoma Week is being celebrated from 7 to 13 March, that is the next week, as a global joint initiative between World Glaucoma Association and World Glaucoma Patient Committee to raise awareness on glaucoma. World Glaucoma Day is observed every year on March 12th, is to raise the awareness about glaucoma and to alert everyone to have regular eye and optic nerve checkups to detect glaucoma as early as possible. Another subspecialty of ophthalmology, which is quite overlooked, rather neglected, is uvea and inflammation. Yes, uveitis can be serious, leading to permanent visual loss. Early diagnosis and treatment are important to prevent complications and preserve your vision. Well, the credit of uvea and its awareness in India goes to my guru, Dr. Jyotirmay Biswas, and so also to Dr. Professor Amod Gupta, sir. Today, we have young Turks in uvea who has taken UVS to a new height in our country. 2 of them are our co-host or quiz masters, and 2 are as a special guest who will be giving the pearls on the topic of uvea. Brain Teasers is privileged to have Dr. Anirudh Agrawal from Cleveland Clinic, Abu Dhabi, and Dr. Partho from Shankar Netralaya, Chennai as my co-host. I welcome Dr. Anirudh and Dr. Partho, and Brain Teaser team is indebted to them for being with us. We are also privileged to have Dr. Padma Malini, Uveitis consultant from Narayan Netralaya. Does anything click when you hear the word Dr. Padma Malini? Yes, she is the lady who described chikungunya, and the citations grow in her name from our country. We are proud to have you, Dr. Padma Malini, and welcome. Another doyen and today's guest is Dr. Samia Basu, head of the Department of Uveitis at LV Prasad Bhubaneswar campus, and he will be delivering the pearls on ocular tuberculosis diagnosis and management. All these big shows and big prizes are not possible without the generous financial support of our trade partners. Team Brain Teasers is indebted to Mr. Ashokan, Executive Vice President, and Mr. Navneet from Microvision for being steadfastly with us. And last but not the least, let me introduce the backbone of Brain Teasers, Dr. Shilpi, who is also one of our co-hosts. My special thanks also to Numerotech team headed by Mr. Sai, for being technical support and conducting the technical part seamlessly episode after episodes. So friends, on this spring Sunday, first Sunday of the spring, let us begin our review with the stalwarts. Over to you, Shilpi, for familiarizing the rules of the game.
Good morning, friends. So now I again familiarize you all with the rules. So who can participate? Yes, it is for all the ophthalmologists from PGs to practitioners. This session, we have 5 sections. Section 1 to 4 will be MCQ based, and you will get 20 seconds for each question. And in each section, we will be having 5 questions. Section 5 will be the rapid fire round. And in this round, you will get 5 questions for 30 seconds. This is what the participants will see on their screen for MCQ round. This is a sample question. Identify the character. Option A, Tom. Option B, Jerry. Option C, Donald. And option D, none of the above. After this, the timer will start. And this timer will play for 20 seconds. Now, here the correct option is option B. So you need to first press the option B and then click on the save button to register your answer. If you will not press the save button, your answer will not be registered with us. Assessment will be done depending upon the correct response and the fastest finger first. This will be for the MCQ rounds. Now, who will qualify for the rapid fire round? The section toppers of the 4 sections will automatically qualify for the rapid fire round. Besides that, the 3 cumulative performers will be qualifying for the rapid fire round. In total, we will be having the 5 winners of today's quiz. In case there is a tie, 3 questions will be asked and the contestant with maximum correct answer will qualify for the respective prize. Finally, the judges and host decision will be final. So now let's see what are the prizes. The 5th winner will carry away 1500 rupees gift voucher. In the ascending order, it will be 2000 rupees, 2500 rupees, 4000, and the winner will carry away the 5000 rupees gift voucher of the Amazon. So section toppers and the 3 cumulative performers will be invited to come live for the rapid fire round. They will be sent a Zoom link to permit them to join to the platform live. So toppers and the cumulative performance, be ready and keep your registered mobile number on, and as soon you get the call, you need to log in. Now I introduce our first quiz master, Dr. Anirudh Agrawal, who is at present Associate Staff Physician at the Cleveland Clinic, Abu Dhabi. He was Assistant Professor at PGI Chandigarh. He did his clinical research fellowship from Stanley, USA. He did his surgical vitreoretinal fellowship from PGI Chandigarh. He received the prestigious Kataria Memorial Gold Medal Award from Prime Minister of India in 2014. At such a young age, he has authored more than 220 publications and written the 40 book chapters. His areas of interest are ocular imaging, retinal diseases, and uveitis. Over to you, Dr. Anirudh.
Thank you very much, Dr. Shilpi and Dr. Bhavankule sir, for the kind invitation and introduction. I think we are all set to begin with the first section of our quiz. So Dr. Shilpi, if you tell me go ahead, I can start.
Yes, Anirudh, you can.
Okay, so let's see the section 1. So our first question is, what clinical feature is not characteristic of Fuchs heterochromic uveitis? As we all know, we have 20 seconds for this. The options are iris atrophy, glaucoma, posterior synechiae, and posterior subcapsular cataract. Time starts now. All right, so the correct answer is posterior synechiae. So posterior synechiae are not observed in patients with Fuchs uveitis, and the occurrence of posterior synechiae in fact actually goes against the diagnosis of Fuchs. Intraocular lymphoma is another condition which does not have synechiae, and you must know that 50% eyes with Fuchs uveitis can have glaucoma, and of course cataract is one of the important cause of visual loss in this disease. So moving on to the next question. In acute viral anterior uveitis due to varicella, which features are not found? So the option 1 is severe vitritis, diffuse or sectoral iris atrophy, cyclitic membrane, and hypopyon. So the time starts now. Okay, the time's up, and the correct answer is cyclitic membrane. Of course, in acute anterior uveitis, cyclitic membrane is not found, and the incidence of severe vitritis is more than 70% in patients with varicella. So even if you have anterior uveitis, the incidence of vitritis is quite high. In addition, diffuse or sectoral iris atrophy is well known, and hypopyon can occur in up to 30% eyes. So cyclitic membrane is not a feature of acute disease. Moving on to a third question in section 1. So, which feature is not found in patients with Eales disease? Is it repeated vitreous hemorrhage, choroidal inflammation, neovascularization of the retina, or optic nerve edema? And the time starts now. And the time's up. The correct answer is choroidal inflammation. Eales disease is an occlusive retinal vasculitis. It's primarily a retinal disease. It's mostly tubercular in etiology. And one of the characteristic features is retinal neovascularization, repeated hemorrhages, and optic nerve head edema. Often these patients actually present with vitreous hemorrhage, and this is usually at the end stage when the inflammation is burnt out. Whenever you do an ICG or if you do an OCT, you'll realize that the choroid is spared, and the appearance on the imaging and clinically the choroid appears to be normal. All right, moving on to our fourth question. Which description is true for acute retinal necrosis? Now the trick here is to be fast because we have long options. So the option 1 is multifocal coalescing deep posterior retinal necrosis. Then you have full thickness granular lesions, retinitis with hemorrhages, fuzzy yellow lesions with subretinal fluid and pigmentary changes, and finally peripheral full thickness necrotizing retinitis, vitritis, and occlusive vasculitis with arteriolar narrowing. Time starts now. All right, so the answer is peripheral full thickness necrotizing retinitis, vitritis, and occlusive vasculitis with arteriolar narrowing. Remember, ARN is a full thickness retinitis. It occurs in association with retinal arteritis, which is an integral feature of this disease. There is occlusion of the vessels and presence of overlying hemorrhages. And the final question for the section 1 is, features of toxoplasmosis are all except focal choroidal thickening, vitreous cells, full thickness retinal necrosis, and absence of vascular inflammation. And your time starts now. So the correct answer is absence of vascular inflammation. Remember, toxoplasmosis is a retinochoroiditis. So of course you have retinal involvement and choroidal involvement. And vascular inflammation is typically exuberant, and it can be termed as Chiaralis plaques, which can happen due to exuberant vasculitis. There can be venous involvement also, and the choroid is focally involved with inflammation. So this is it for section 1. And it's my pleasure and honor to introduce to you Dr. Parthopratim Datta Majumdar, sir, who is a quiz master with me. He's a senior consultant at the Department of Uvea and Intraocular Inflammation, Shankar Nethralaya, Chennai. We all know him so well because he's published so many articles in various journals, a prolific writer, written several book chapters in various books, and actually edited 4 books. We love him for his efforts that he's put in making a popular ophthalmology portal, that is eophtha.com, and he comes up with such wonderful blogs every now and then. So over to you, sir. I'll stop sharing my screen.
Thanks, Anirudh. Let me. My slides are visible. Yeah, thank you, Anirudh, for your kind introduction. So, good morning, friends. I would like to thank Dr. Prashant Bavankule and Dr. Shilpi for having me here. So, without any delay, let's start the section 2. So, all ready? Dr. Shilpi, can I proceed?
Yes, sir.
Yeah, so my slides are visible and you can hear me.
Yeah.
So the first question of the second round is, which of the following parameter is not included in international study group criteria for Behçet disease? Okay, so your options are eye lesions, any uveitic eye lesions. Second option is pathology test. Option C is HLA-B51, and the option D is skin lesions. And your time starts now. Time's up. So what is the correct answer? The correct answer is HLA-B51. So HLA-B51 does not rule out or rule in the presence of Behçet disease because it is present in only 50 to 70%. Similarly, few clinical lesions like we talk about mobile hypopion. So mobile hypopion is very less specific finding in Behçet disease, seen in approximately 30% of the cases. So only mobile hypopion, remember, only mobile hypopion is not a characteristic finding to diagnose a Behçet disease. Similarly, pathology test, it is included in international study group criteria, but in practice, it is rarely done in ophthalmology practice because it is mainly useful in the mucocutaneous lesions. But yes, it is included in the diagnostic criteria of the international study group classification. So coming to our second question of the second round. So this round will be dealing with the laboratory investigations in uveitis. So the second question is, which of the following is not helpful for the diagnosis of sarcoidosis? So I repeat, not helpful for the diagnosis of sarcoidosis. Your options are serum angiotensin converting enzyme levels, a high resolution computerized chest, Montu test, and lymphocytosis. So your time starts now. Time's up. So how many of you clicked C, the Montu test? Our correct answer is lymphocytosis. So why this basically the lympho, it is the leukopenia which is observed in sarcoidosis, and you have to remember that the serum angiotensin converting enzyme and the lysozyme, these are grouped together and they represents the granuloma load in the body. But the disadvantage is sometimes when you are dealing with the ocular sarcoidosis, it may not be a correct marker to predict the ocular disease. HRCT is highly valuable for diagnosis of the bihilar lymphadenopathy, and negative energy to the tubercular protein, that is PPD, is a characteristic of sarcoidosis. So when you see a case of granulomatous uveitis and do a Montu test, it helps either way. If it is positive, it can lead you to a diagnosis of the it can help you to diagnose ocular tuberculosis. And even if it is negative in a granulomatous case of uveitis, it can help you to pick up sarcoidosis, or at least you can think that the patient is having energy, negative energy to the tubercular protein, so it can have a sarcoidosis. So coming to our third question, it's a case scenario. A 9-year-old child with bilateral iridocyclitis and macular edema has presented to your clinic. Now, when you examine the child, the child is having remarkable, unremarkable fundus findings, but you can notice that there are macular edema. Now, this child's parents inform about the malaise, fatigue, and fever, and symptoms like weight loss, for which they went to a nearby pediatrician, and pediatrician has done all the laboratory investigations. But laboratory investigation shows elevated blood urea nitrogen and creatinine. Now, my question is, which investigation you will perform next in this particular 9-year-old child with bilateral iridocyclitis and macular edema? No other fundus finding. I give you a clue. There is no pars plana exudates also in this child. Only bilateral iridocyclitis and macular edema. Your options are option A, Montu test, option B, MRI brain, option C, serum beta 2 microglobulin, and option D, torch titers. Your time starts. Child with bilateral iridocyclitis with macular edema, fundus otherwise normal. Preliminary blood test shows elevated blood urea nitrogen and creatinine. So your correct answer is serum beta 2 microglobulin, because we are suspecting here tubulointestinal nephritis and uveitis syndrome, that is TINU. So it has been seen that though these are not very pathognomic or very clear-cut marker, but beta 2 microglobulin levels in their, it is raised in their urine and serum, though the confirmatory diagnosis is possible through the renal biopsy. So move on to the fourth question of this section. So which of the following investigation is usually not advised in a patient with vitritis and pars plana exudate? Now we are giving you an option where there is no specific symptom of or sign of a particular disease, but you are observing a patient, you are examining a patient with vitritis and pars plana exudates. Which of this investigation you want advice? Number one, Montu test. The second option is your C-ANCA. The option C is serum angiotensin converting enzyme, and option D is HRCT chest. Your time starts now. Time's up. So the correct answer is C-ANCA. So in absence of specific symptom and sign, the antinuclear cytoplasmic antibody has very rare role that it will cause intermediate uveitis. It's very, very rare association. So one should not advise this test unnecessarily in a patient with pars plana exudate and vitritis. So the last question of this round 2, false negative Montu test can be seen in all these conditions except. Your options are very recent TB infection, option B, very old TB infection, option C, chicken pox, option D, previous BCG vaccination. And your time starts. Very recent TB infection and very old TB infection. Option C, chicken pox, and option D, previous BCG of vaccination. So how many of you click chicken pox? So your correct answer is previous BCG vaccination. It will give rise to false positive Montu test. Now, Montu test, it is named after a French physician, Charles Monteux. And as we know that in your clinic, whenever you see a case of uveitis, irrespective of its clinical phenotype, there is a tendency to advise the Montu test, especially in India. And sometimes we unfortunately we see that some patient, irrespective of the clinical phenotype, we just start the patient to ATT or ask the patient that the patient is having ocular tuberculosis only on the basis of positive Montu, which is often not correct. Dr. Basu is there, who has done pioneering work on ocular tuberculosis. He will share more on that. But just few points that Montu's positivity was seen in approximately 67 to 90% of the healthy adults in Indian population in a study long back in 1975. So in a study, so it's very common in India that any patient can have positive Montu. So it's not characteristic that the patient is having this disease. Second important thing for the ophthalmologists, those who are prescribing both the Montu test and the interferon gamma release assay, that is quantiferon TV Gold, popularly it is known as the commercially available. So what happens that the prior intradermal injection of the Montu or the PPD, it can boost the interferon gamma release assay and can lead to false positive results. So it is always better to collect the blood samples and then only to inject the PPD in this patient. So always send the patient for blood collection, whatever investigation you are suspecting, and then only subject the patient for the PPD injection. So over to Anirudh for the next round. I'm just I'll just stop sharing my.
So meanwhile, we have the section 1 winner with us, Dr. Hetal Patel from Gujarat. So congratulations, Dr. Hetal Patel. You need to continue playing so that you can be eligible for the final prize, because that will calculate the cumulative performance of all the sections plus rapid fire round. And do remember to join us on the Zoom platform. Okay, and we have section 2 winner also, Dr. Anupama Jayan from Kerala. So congratulations, Dr. Anupama. Over to you, Dr. Anirudh.
Thank you very much. So we're all set to begin with section 3, which is on imaging in uveitis. And our first question is, what is a feature of inflammatory CNV on OCT? So is it pitchfork sign, rain cloud sign, umbrella sign, or vertical lines of Zar? And your time starts now. Okay, so the time's up and the correct answer is pitchfork sign. So pitchfork sign is a feature of, it's a part of the inflammatory CNV on OCT, and it's a characteristic feature which appears as vertical lines arising from the subretinal hyperreflective material. The rain cloud sign is a feature seen in fungal endophthalmitis when there is spillover inflammation from the retina into the vitreous cavity. Now, the other two signs simply don't exist. I just made it up. But what's important to note is that when you have subretinal hyperreflective material in eyes with posterior uveitis, even if there is no intraretinal fluid or subretinal fluid, you must suspect an active CNV. And OCT angiography works very well to document these new vessels. And these patients, when they're treated, this subretinal hyperreflective material can reduce in size, and also the visual acuity may improve, and you may find improvements in the metamorphopsia. So moving on to the next question of section 2. So which feature is true regarding acute zonal occult outer retinopathy, or AZOR? Is it intraretinal fluid is common on OCT? Option B is there is choroidal thinning due to viral necrosis. Option C is autofluorescence shows trizonal defect. And option 4 is OCT shows loss of RPE. And your time starts now. So the correct answer is autofluorescence shows trizonal defect. Now we know that azure is one of the difficult entities that we encounter in our practice. And this is a condition which shows trizonal typical defect on the autofluorescence. And it's presumed to be a viral disease, but remember, it does not represent an active viral infection. So we don't necessarily treat patients of azure with antiviral agents, like we do it for retinal necrosis. In fact, these patients are rather they're treated with steroids or immunosuppression. And usually we don't find there is intraretinal fluid. If you look at the OCT that I showed you with the question, that's a very characteristic feature of loss of photoreceptors, and the RPE is mostly preserved. So with that, we move to the next question, question number 3. What is a feature of intraocular lymphoma on OCT? Is it a pigment epithelial detachment? Is it thickened hyaloid, sub-RPE bumps, or is it stalagmite-like deposits? And your time starts now. All right, so the correct answer is sub-RPE bumps. This is a characteristic finding of intraocular lymphoma with a very high predictive value for the disease. Pigment epithelial detachment is a non-specific finding which you find in conditions of pachychoroids such as central serous chorioretinopathy or Vogt-Koyanagi-Harada syndrome, and thickened posterior hyaloid and stalagmite-like deposits on the retina. They have features in infectious uveitis such as toxoplasmosis or viral retinitis. So we usually don't find those in eyes with lymphoma. And this is a very important imaging finding in patients, especially those who have CNS lymphoma. And if you find these changes on the OCT, you must suspect an ocular disease. Next question is, which is not a feature on OCT in VKH disease? So the option 1 is compartmentalization of fluid. Option 2 is subretinal fluid. Option 3 or C is choroidal granulomas. And option D is focal excavation of the choroid. And your time starts now. So the time's up, and the correct answer is focal excavation of the choroid. So we all know that, like you see in this OCT, compartmentalization of fluid in different pockets is very common in VKH. You can have subretinal and intraretinal fluid, and typically there is a split in the photoreceptor zone, which is called as basilar layer detachment, which is a feature on the OCT in VKH. And in fact, there have been studies which have looked at the properties of the fluid contained in the subretinal and intraretinal spaces in VKH. Stromal choroidal granulomas are a characteristic of VKH disease, as also sympathetic ophthalmia. So we're going on to our last question of the section 3, which is not a feature on OCT in punctate inner choroidopathy. So is it RPE elevation, choroidal stromal thickening, inflammatory choroidal neovascularization, or intraretinal fluid? And your time starts now. Okay, the time's up, and the correct answer is choroidal stromal thickening. Now we know that punctate inner choroidopathy is actually a choriocapillaritis. It's a disease of choriocapillaries and the outer retina RPE with sparing of the stromal choroid. So usually you don't find any stromal involvement, and there is a high incidence of inflammatory CNV in these eyes, with more than 75% cases having an underlying CNV. These can present with intraretinal fluid, subretinal fluid, and RPE elevation. So with this, I'm going to stop sharing my screen, and it's over to Partho sir for the section number 4. Thank you.
So now the section 4. So before we go to the questions, so there are 7 rapid fire rounds, and we have prepared some exciting questions for this rapid fire, me and Anirudh. So just stay tuned. So going to the section 4, the section 4 will be on treatment of uveitis. So very interesting, without any clinical picture, but I'll show you very highly interesting questions. So my first question is, which cycloplegic agent is not used routinely in the treatment of anterior uveitis? So all of us, when we treat anterior uveitis, we prescribe one topical steroid and we prescribe one cycloplegic. So now, which of the cycloplegic ideally one should not prescribe in his routine practice while treating a case of anterior uveitis? Your options are: option A, atropine; option B, homatropine; option C, cyclopentolate; option D, phenylephrine. And your time starts now. Atropine, homatropine, cyclopentolate. How many of you clicked atropine? So ideally, one should not use cyclopentolate at any cost. This is what happens. This cyclopentolate is not used routinely in anterior uveitis. Why? Because it is chemoattractant in nature. So if you are using cyclopentolate in anterior uveitis, I know you will tell that the phenylephrine is not a cycloplegic, but even if you are using phenylephrine, it won't cause cycloplegia, but won't cause any harm. But if you are using cyclopentolate, it is chemoattractant in nature. So that means the drug, the molecule itself can attract the mediators of the inflammation to the site of the inflammation in normal patients. So imagine what can happen in anterior uveitis. So that's why our answer is C. Cyclopentolate should be avoided in a case of anterior uveitis because of its chemoattractant properties. Now, the next question is about let's see what are the options. So my question is, which of the eye drop is formulated and marketed as emulsion? The number 1, prednisolone acetate, 1%, dexamethasone sodium phosphate, 0.1%, difluprednate, 0.05%, and homatropine, 5%. Your time starts now. 4 options. You have to select which of the drug is formulated as emulsion. Time's up. So prednisolone acetate, it is actually formulated as suspension. The dexamethasone sodium phosphate it is available as solution, and correct answer is the C, the difluprednate, 0.005%. So what happens, instead of water, we use oil for preparing the emulsion eye drops. So that's why difluprednate is the correct answer. For our viewers, if you remember, the solutions are more effective than the suspension drug like prednisolone acetates are more effective than the solutions like dexamethasone sodium phosphate. But one needs to shake this bottle properly to achieve the desired level of the concentration. So that's why it is written that shake well before use. So that is very important. If your patient is using prednisolone acetate suspension and there is no desired results in the reduction of inflammation, you have to inquire and ask your patient that whether the patient is shaking the bottle properly before using, because that is very important. Now, it has been seen that the prednisolone acetate has much more higher efficacy than the solutions like dexamethasone sodium phosphate. But one problem with the suspensions are they form cake formation. Like you'll see the patient who are using the topical steroid, there are Uveitis deposits over the lead margins. So these are characteristically called cake formation with the suspensions. So sometimes the patients on suspension like prednisolone acetate, they complain of foreign body sensation. So this occurs because of this cake formation, which causes foreign body sensation. So that's why the difluprednate was introduced to reduce this cake formation with higher efficacy, because it contains oil, so there is no formation of sedimentation in these patients. So moving to our second question. Second question is very easy. I think all of you know the answer. So which one of the following immunosuppressive? I'll show you 4 names of the immunosuppressives. You have to tell which one of them is not an anti-metabolite. Your options are azathioprine, option B, cyclosporin, option C, methotrexate, option D, mycophenolate mofetil. Your option starts now. Time's up. So antimetabolite actually work by mimicking the molecules that is cells need to grow. Now we know that every human body cells need some feeding element to grow. Now this cell, what happens in antimetabolite, the cells are actually tricked to take these drugs, these antimetabolite drugs, instead of their normal building blocks of the genetic material. Like why we need these cells need something to feed, because they need for their genetic material like RNA and DNA. So what happens in antimetabolites? The antimetabolites, they trick the cells to take this drug molecule instead of the normal building block. So that's how they actually trap the cells and exerts their action. Now, one can ask, what is the difference between the corticosteroid and antimetabolite? Why would we talk about antimetabolite when there is corticosteroid? Now, one fundamental difference between antimetabolite and corticosteroid is antimetabolites are cytotoxic. They are lethal to the cells. Whereas corticosteroid, they mainly act by, especially if you take about the lymphocytes, the antimetabolite will actually lethal to these cells. Whereas the corticosteroid, they will act about diverting the lymphocytosis from intravascular spaces. They will divert this lymphocytosis into the extravascular spaces and exert their action. So that's the fundamental difference between the antimetabolites and the corticosteroid. So cyclosporin is the correct answer. It is not an antimetabolite. It is a calcineurin inhibitor. So let's move to our question number 4. Now you have to tell me, I'm talking about a drug. It inhibits the enzyme dihydrofolate reductase. I think everyone is ready. They know the answer already. So let me read this question properly and options. It inhibits the enzyme dihydrofolate reductase, inhibiting the production of the tetrahydrofolate, which in turn inhibits formation of the thymidylate, leading to inhibition of DNA replication and RNA transcription. Whatever I have discussed in the previous question, I have framed the same question in a different form. Now, which drug I'm talking about? Remember, it inhibits the enzyme dihydrofolate reductase and exerts their action by inhibition of DNA and RNA transcription. Which drug I'm talking about? Options are methotrexate, trimethoprim, pyrimethamine, all of them. Your time starts now. Basically, we are talking about dihydrofolase reductase inhibitor. You have to identify which one of the drugs inhibits enzyme dihydrofolase reductase. Time's up. So, how many of you clicked methotrexate? You are absolutely right. The answer is methotrexate. Correct answer is methotrexate, but not only methotrexate. The correct answer is A, methotrexate. The correct answer is B, trimethoprim. The correct answer is C, pyrimethamine. So all of this drug actually inhibit the dihydrofolate reductase. In basically they inhibit it in human cells like methotrexate, in bacteria by trimethoprim, and in protozoa by pyrimethamine. So all of them are dihydrofolate reductase. So let's move on to the last question. I think Dr. Shilpi is getting ready with the mark of the round 3, and round 4 will be coming soon. So methotrexate, very simple question. Methotrexate is not administered through which route? Your options are subcutaneous, option B, intravitreal, option C, subconjunctival, option D, oral. And your time starts now. Time's up. It's, I think, the easiest question of this quiz program. So the option is subconjunctival because of its toxicity. However, it has been used, mostly used as an injectable form in subcutaneous route. Intravitreal injection has been tried in intraocular lymphoma and cases where the serpiginous choroiditis is not responding to the conventional treatment, and oral we know it is. So it is, correct answer is option C. So over to you, Dr. Shilpi.
Yes, sir. Thank you, sir. Thank you, Dr. Anirudh, for conducting the MCQ round so well. So we are ready with the third section winner, Dr. Vishnu Deepti Narayanam from Vizag, Andhra Pradesh. So please do log in, and we will need to play the rapid fire round with you. Shortly, we will announce the section 4 winner and the 3 cumulative winners. Meanwhile, I'll share my screen. So, my proud privilege to introduce Dr. Padma Malini ma'am. She is the head of Uveitis and Ocular Immunology Services from Narayana Nethralaya, Bangalore. She is a DNB coordinator there. She is a member of International Uveitis Study Group and International Ocular Inflammation Society. She is treasurer of Society of Inflammation and Research. She is the executive and scientific member of Uveitis Society of India. She had more than 150 publications in her name. She has written more than 35 book chapters and was awarded with 11 awards. So with this, I'll play her video.
Very good morning to all of you. At the outset, I'd like to thank Dr. Prashant and the entire Brain Teasers team for inviting me here today to speak to you all clinical clues in uveitis. In the next 5 minutes also, I would like to give 5 clinical clues on flukes uveitis, viral uveitis, and how are we going to differentiate between central serous chorioretinopathy and choroiditis. Syphilitic retinitis is a great mimicker, followed by masquerades. The first one is on Fuchs uveitis syndrome. It's called as Fuchs heterochromic iridocyclitis. Heterochromia can be present in Fuchs uveitis, but may not be in all the cases. They are characterized by white uveitis, diffuse, fine, and stellate keratic precipitates, and they can develop complicated cataract. However, there is no posterior synechia, no cystoid macular edema. These patients, we don't treat them with corticosteroids. In spite of active inflammations, they can undergo cataract surgery. We have to watch out for secondary glaucoma. The recent classification criteria for Fuchs uveitis characterized by the presence of anterior uveitis and also the vitritis. However, we need to rule out other causes like CMV infections, herpes simplex, and varicella zoster virus uveitis have been excluded from Fuchs uveitic entities. Next is a viral uveitis. Viral uveitis have characteristic morphological pattern. Based on that, we can diagnose. One, varicella zoster virus is characterized by sectoral iris atrophy, whereas diffuse patchy atrophy is seen in herpes simplex uveitis. Both have diffuse pigmented keratic precipitates across the cornea. Next is acute retinal necrosis, where we have focal demarcated retinal necrosis in the peripheral retina. They have a circumferential progression associated with occlusive vasculopathy with significant vitreous inflammation. The recently revised diagnostic criteria for the ARN includes only HSV and VZV infection. It excludes cytomegalovirus and toxoplasma infection. If the patients have more than one infection, that also have been excluded from the list. Types of viral retinitis. In addition to ARN, we have other viral uveitis such as PORN and CMV, or have necrotizing retinitis. ARN has a Swiss cheese pattern. PORN has a cracked mat appearance. CMV, it's a pizza pie appearance. Whenever we have a necrotizing viral retinitis, it's important that we need to start the patient at the earliest. Molecular diagnostics help us to confirm the diagnosis. No systemic steroid should be started without establishing the exact etiology or putting up an antiviral cover in case of necrotizing viral retinitis. The third, how are we going to differentiate between central serous chorioretinopathy and choroiditis? Both looks like yellowish lesion. Here is a fundus photograph showing central darkening within the yellowish red area. Whenever we see a central darkening, we need to suspect central serous chorioretinopathy, whereas choroiditis have the lesions underneath the retinal blood vessels. Next comes FFA. FFA has early pinpoint hyperfluorescence, which increases in the late phase as classical ink blot appearance, what is described in CSER. In the left eye, the choroiditis will have early hypo with late hyperfluorescence. So in CSER, we have hyper to hyper. In choroiditis, we have hypo to hyper. Based on this, we can differentiate between CSER and choroiditis. It's important because the management is going to be different in both the conditions. The next is a great mimicker. Syphilitic retinitis can present in the form of focal, multifocal, or diffuse retinitis. In the syphilitic retinitis, we have placoid chorioretinitis, triangular patch of retinitis, punctate inner retinitis. These are the classical form of syphilitic chorioretinitis. The next comes masquerades. Whenever we see a patient with extremes of age group with atypical presentation, it is important that we rule out masquerades. Whenever we come across a patient with pseudo-hypopyon, retinal infiltrate, or rod spots, our antenna has to go up to rule out masquerades. Pseudo-hypopyon in a child, we need to rule out retinoblastoma. Here is the retinal infiltrate with the smoldering pores in a case of an intraocular lymphoma, rod spots here in the case of leukemia. The OCT biomarker can help us to pick up these masquerades. Abnormal OCT reflectivity, the lumen is filled with hyperreflectivity with loss of figure 8 configuration is seen in a case of a myeloid leukemia. Vertical hyperreflective lines and subherpes deposits are seen in the case of an intraocular lymphoma. To conclude, a detailed history and thorough clinical examination remain the most important diagnostic tool for uveitis evaluation. Working on diagnosis is like being a detective, putting the unlikely clues together to arrive at a correct diagnosis. Thank you for your attention. Wishing you all the best for the quiz to all participants. Thank you, one and all.
Excellent tips, ma'am. Really learned so many new things. So one question I want to ask, ma'am, in a busy OPD schedule, so when should one clinician suspect intraocular lymphoma in a patient? Your just practical tips.
Intraocular lymphoma, they have yellowish white lesions, smoldering choroiditis. Initially, they may respond to steroids, but may not have complete recovery. But the clinical clue, the OCT biomarker can help us to identify, like I told, in early lesions, we will have a vertical hyperreflective lines or sub-RP deposits, like Dr. Aniruddha also has put it up in the imaging question. So these two clues can help us to suspect intraocular lymphoma. However, the diagnosis, either by the vitreous biopsy or the retinochoroidal biopsy, the indirect markers like interleukin 10/6 ratio also can be helpful in cases of intraocular lymphoma.
Okay. Ma'am, those who don't have OCT, for them, like when they should refer a patient to uvea specialist or to a retina.
And also I wanted to, whenever you have a whitish deposits, the clumps of cells, they're slightly larger than the posterior uveitic vitreous cells. If the patient is not responding to steroids and they are getting recurrent yellowish lesions in the fundus, patients associated with headache, if they have associated CNS lymphoma. So these kind of cases, when you extremes of elderly individual, better to refer to the eye center to rule out lymphoma than managing it, because the delay is going to affect the prognosis in these cases. In addition to the OCT biomarkers, we also recently described the confocal deposits, and we have seen a classical floral pattern of deposits in case of intraocular lymphoma. Following treatment with intravitreal methotrexate and systemic chemotherapy, this pattern reverts to a normal one.
Thank you, ma'am.
So thank you, sir. Thank you, ma'am. So we have the section 4 and the cumulative 3 winners with us. So section 4 winner is Dr. Rinki Shah from Kolkata. The first cumulative winner is Dr. Nikita Gupta from Chandigarh, Dr. Panchami Gupta from New Delhi, and Dr. Gaurav Mazumdar from Kolkata. So congratulations. Please do join at the earliest so that we can start with that rapid fire round. Any more questions, Partho sir or Anirudh sir from ma'am?
I think ma'am has really given a very lucid and clear talk on so many, wide variety of diseases. Thank you so much, ma'am. We learned so much from you.
Thank you.
So nothing is possible without the generous support from the financial support from the company. So there is a commercial break and ad from their end. So thank you, Microvision team. Thank you, Ashok sir, Navneet sir. So we could see that Dr. Hetal Patel, Dr. Anupama, Dr. Vishnu, and Dr. Gaurav have already joined. So we can start with the rapid fire round. Meanwhile, rest of the 3 contestants can join us on the Zoom platform. So over to Dr. Anirudh for the rapid fire round.
Thank you very much once again. I'll just share my screen. So all right, so we can begin the section 5 on rapid fire. Just to recapitulate the rules, we have each question is 30 seconds. So each candidate is 30 seconds, and we have 5 questions that we need to answer in 30 seconds. Remember that your first answer is valid. And if the time is called during the question being read, you have 3 seconds to answer after the completion of the question. There is a 50% negative marking, so be very careful when you're giving your answer. Remember, 5 questions in 30 seconds, so you have to be really fast in the rapid fire. So Dr. Shilpi, just wanted to confirm with you, can we start with the first candidate?
Yes, so the first candidate is Dr. Hetal Patel from Gujarat. So Dr. Hetal Patel, please switch on your mic and your video. Dr. Hetal Patel, can you hear me? Dr. Hetal? So we can move to the another contestant, that is Dr. Anupama Jayan from Kerala. Dr. Anupama?
Dr. Anupama is saying that she cannot unmute. So maybe,
Sai,
can you help the participants to unmute themselves and switch on their audio, video and audio?
Sai,
Yeah, madam.
can you help Dr. Anupama?
I think the participants who just
She's
joined,
there already.
they cannot unmute themselves. They cannot unmute and switch on the video. Maybe they need additional privileges.
Ma'am, can you announce once Dr. Hetal Patel, she has to join again because she has not joined properly. I think there is an internet issue.
Dr. Hetal Patel, please join again. Just Dr. Hetal Patel, can you hear? No response. I think you can call her. Navneet ji.
Sure, ma'am.
Now, how about Dr. Anupama? Can you unmute now?
Meanwhile, we can move forward to the section 3 winner, Dr. Vishnu Deepti. Dr. Vishnu.
Yes, ma'am. Am I audible?
Yes, you are.
Yes, you are.
Is my video on?
Yes.
Yes.
So please do introduce yourself in 2 lines, Dr. Deepti, Dr. Vishnu Deepti.
I'm a fellow in India from Shankar Netralayam, and I'm from Vizag.
All right. So you're ready to start with the first part of the rapid fire. You're the opening batsman.
Yes, sir.
Okay. So remember, we have 30 seconds starting now. What is the literal meaning of the name Iris? Or where is it originating from?
I don't
You have
know.
yes, no, and pass.
Oh, no.
Okay.
Pass.
Scleritis in a patient with swan neck deformity. Identify systemic disease.
Rheumatoid arthritis.
Okay. Amsler sign can be seen in which condition?
Fuchs.
True or false? Mycophenolate can cause severe bone marrow depression.
True.
What's the diagnosis?
Viral.
Okay. So let's see the correct answers here. So the literal meaning of the name Iris, the origin is goddess of rainbow. And you were right in saying that scleritis in a patient with swan neck deformity is rheumatoid arthritis. Amsler sign can be seen in Fuchs. That was correct. Mycophenolate can cause severe bone marrow depression is false. Okay.
So she got, one answer is.
Yes. And what is the diagnosis? You said viral, but that's incorrect. The correct answer is Fuchs uveitis.
So she got 2 correct and 2 wrong. So finally.
Yeah, so she got the rheumatoid arthritis correct and Fuchs uveitis correct. So 2 right.
It's okay. Yeah? We don't know his answers. So,
Okay, well done, Dr. Vishnu. Thank you so much.
Dr. Hetal, can you hear us now? Dr. Hetal Patel or Dr. Anupama Jayan? Dr. Rinki Shah is yet to join, I think. So we can start with Dr. Nikita Gupta. Dr. Nikita?
Hello.
Yes, Dr. Nikita.
Yes, ma'am. It says something.
Yes, yes. Yes, we can see you and we can hear you also. So welcome back, Nikita. She's
Hi,
our
Nikita.
Yes. So Nikita, again introduce yourself because she is our constant, Zoom participant.
Hello, everyone. I'm Nikita. I'm currently doing MCH in Vitreoretina from PGI Chandigarh.
Okay, so Nikita, you're ready? You're the overall topper, number 1. So we can start your set of questions.
Yes, sir.
Okay, so 30 seconds, the time starts immediately. So try to answer as soon as you can, okay? What is the literal meaning of the name uvea?
Pass.
Retinal vasculitis in a patient with butterfly rashes identify systemic
SLE.
condition. Sorry?
SLE.
Okay, headlight in fog can be seen in which condition?
Toxoplasma.
Okay, TNF alpha blockers can cause sarcoidosis like reaction. True or false?
Pass.
Pass. Which condition do you get these corneal endothelial lesions?
TB.
No. So the correct answers that you gave, so yes, the name uvea comes from grape. Retinal vasculitis in a patient with butterfly rash, you're right, it's SLE. Headlight in fog, you're right, it's toxoplasmosis. TNF alpha blockers can cause sarcoidosis like reaction is true. You said pass. So which condition do you get these corneal endothelial lesions? So coin lesions in CMV, anterior uveitis, and you said TB, so that will be counted as incorrect. Okay, thank you so much, Nikita.
Okay, sir. Thank you, sir.
First answer she gave was correct or wrong?
The first answer, she said pass.
Yes, okay. Okay. So she got 2 correct and 1
2
wrong.
correct, 2 pass, and 1 incorrect.
So the next in line is Dr. Panchami Gupta. Dr. Panchami Gupta?
Yes, ma'am. Can you see me?
Yes, yes.
Hello, everybody. I'm Dr. Panchmi. I am working as a medical officer in Delhi, Dr. Rajan Babu TB Hospital.
Hi, Dr. Panchami. So you're ready for your set
Yes,
of 5
sir.
questions? So as you
Yes,
know, the time starts immediately. So try to say yes, no, or pass. Okay.
Yes, sir.
Okay. What is the literal meaning of the name staphyloma?
Sir, pass.
Okay. Scleritis in a patient with cauliflower ear. Identify the systemic condition.
Sir, golden heart syndrome? Pass. Golden heart syndrome.
Okay. Candle wax
Sarcoidosis.
dripping.
Sarcoidosis.
Acyclovir is effective against actively replicating virus, not on latent virus.
True.
True. What does ICGA show?
Sir, pass.
Pass.
BK.
Okay. So the little meaning of the term staphyloma is bunch of grapes, and you said pass. Scleritis in a patient with cauliflower ear is relapsing polychondritis, and you were incorrect. You said golden hair syndrome. Candle wax, you were right. You said sarcoidosis. This is correct. True or false? Acyclovir is effective against only the active replicating virus and not on latent virus. That is true. And you said pass.
Sir, I said true.
You said true. I'm sorry. Yes. And what does ICGA show? You said pass. It is choroidal granulomas. So there. Did you get that, Dr. Shilpi? All right. So with this, I am going to put it over to Dr. Partho sir for the next set of questions.
Partho sir? Partho sir, can you hear me?
Partho sir, just now you unmuted. Once again, you unmute, please.
No,
Yeah.
yes, just now. So it is when I'm trying to unmute, it is saying the host is not allowing you to unmute.
Now we can hear you, sir.
So I think one of the participants wrote in the box that she cannot join. So can you have a?
Yeah, I'm helping her. I'm helping her, doctor. Yes.
Okay.
Can you hear us now? Dr.
So,
Anupama?
yeah, so let's wait for the next rapid fire participant. So just to inform our viewers that me and Anirudh, we have prepared this rapid fire question. Basically, the 5 uniform question, the format was same. The first question is on the basis of some common terminology we use in our uveitis practice. The second question is on one systemic sign in uveitis or any patients with scleral inflammation. The number 3 will be a question on ocular signs in uveitis. And number 4 is true or false. And here we have picked up some facts about the pharmacology of the commonly used drug in uveitis. And the number 5, the spotters, the Dr. Anirudh has picked up excellent photographs, clinical photographs of certain conditions. So we'll be using them as a spotter. So any next speaker is next contestant is there.
Dr. Anupama, can you hear us? Dr. Anupama? Can you unmute yourself now?
Ma'am, can you hear me now?
Yes.
Okay, ma'am. Okay.
So, sir, Dr. Anupama, the section 2 winner is the next contestant.
Okay, Dr. Anupama, can you introduce yourself?
So I am now in Kerala Health Service after my post-DO DNB.
Okay. So let's start playing that. So your first question is, what is the full form of sun classification?
Standardization of uveitis nomenclature.
Scleritis in a patient with saddle nose deformity can be seen in which condition?
Syphilis.
Scleritis, okay. Shigura sign can be seen in which condition?
VKH, Voger-Kowanagi-Harada disease.
True or false? Rifabutin can cause hypopyon uveitis.
True.
What is the diagnosis in this picture admitted in a medical ICU?
Pass, sir.
Time's up. Okay. So the answers are, what is the full form of sun classification? It stands for standardization of the uveitis nomenclature, and you have answered it correctly. The second, it's a little, you are factually right, but only the reason I can't give it to you because it is scleritis in patients with saddle nose deformity. But yes, saddle nose deformity can be seen in cases of syphilis. And okay, any form of ocular inflammation can be seen in syphilis, so I'll give it to you. So Dr. Shilpi, please note that it is, we'll consider it as a correct answer. So the number 3 is Shigure's sign that you answered correctly. It is VKH, Vogt-Kowanagi-Harada disease. Rifabutin can cause hypopyon uveitis. I think you have answered it correctly. And number 5, what is the diagnosis? It was a case of actually choroidal tuberculosis. So here, Dr. Shilpi, is it okay?
Yes, sir. Yes, she gave 3 correct, 1 wrong, and 1 was pass.
Yeah. So we'll move on to the next contestant.
So, what, Peter? Second one is, sir said that he cannot give you the mark because it is the scleritis with the saddle nose deformity.
Okay.
And that's when you passed. Okay.
Okay, ma'am. Okay, ma'am.
Sure. So well done, Dr. Anupama. So contestant is Dr. Gaurav Majumdar from Kolkata.
Yes, I am there, ma'am.
Yes, yes.
Yeah.
I can.
Hello, Dr. Gaurav, can you introduce yourself?
Yeah, good morning to everybody. Dr. Parthosa. I've done my MS from CMC Vellore, and I've done my anterior segment fellowship from Arvind Bhai Hospital. And currently I'm employed in private practice, sir.
Okay, welcome, Dr. Gaurav. Glad to meet you here.
Thank
And
you, sir.
your time starts now. So you have to expand the abbreviation of site study.
Pass.
The non-granulomatous anterior uveitis in a patient with bamboo spine appearance. Identify the systemic condition.
Ankylosing spondylitis.
Berlin's nodule can be seen in which condition?
Pass.
True or false? Methotrexate takes 6 to 12 weeks time to act.
True, sir. True.
What is the diagnosis in this patient with systemic malignancy?
Pass.
So here are the answers. So expand the abbreviation of the site study. It's the systemic immunosuppressive therapy for eye disease. Non-granulomatous anterior uveitis in a patient with bamboo spine can be seen in ankylosing spondylitis, and you answered it correctly. The Berlin nodules can be seen in ocular, which ocular condition? It's sarcoidosis. True and false, the methotrexate, you answered it correctly. Methotrexate takes 6 to 12 weeks time to act. And the diagnosis of this condition was Bidam. So Dr. Shilpi, Dr. Gaurav has answered 2 questions.
Correct. And 3 were pass.
Yeah.
Sir, unfortunately, Dr. Hetal Patel and Dr. Hetal Patel messaged that she is in emergency, so she is unable to join.
Okay.
And Dr. Rinki Shah is not picking up the phone. So we played with the 5 contestants.
I think then we can go to the next session.
Yes.
We have our invited talk. Okay. Over to you, Dr. Shilpi.
Thank you, sir. Thank you. So our today's next guest speaker is Dr. Samia Basu. He is the head of uveitis services at LVPI and a consultant retina and uveitis. His interests are in immunopathogenesis of ocular tuberculosis and role of autoimmunity in infectious uveitis. He has been awarded with the various awards by like ARVO Pfizer Award for the Collaborative Research Fellowship, short-term fellowship at University of Cambridge, UK. He is the section editor of UV and inflammation in IJO. He was the DBT Wellcome Trust India Alliance Intermediate Fellowship Award, and he was the member of International Uveitis Study Group in 2020. He has 71 publications and has written 9 book chapters. So with this, I am playing his video from my end. Welcome, sir.
Hello, everyone. I'm going to run you through 10 clinical pearls in ocular tuberculosis, which will help you in the diagnosis and management of this condition. These include 4 clinical signs, 3 diagnostic clues, and 3 treatment guidelines. The first clinical sign is the presence of either healed or active retinitis lesions overlying a blood vessel that has perivascular infiltrates. This is suggestive of tubercular retinal vasculitis in a TB endemic country. The other clinical sign is the presence of these focal vascular tortuosities, which you see here within the area of vasculitis. Now, this we recently reported is again suggestive of a possible tubercular etiology. The third one is the presence of these serpiginous-like lesions, which are not only having this amoeboid margin, but are also multifocal and extend into the periphery of the fundus. These typically start at the posterior pole. They are at different stages of healing. So the autofluorescence will show some as dark, which is healed, while others will have mottled or complete hyperautofluorescence, which is suggestive of activity. The fourth clinical sign is the way to find the location of the active lesion. If it is at the center, like center of a scar, like seen here, it is suggestive of TB, while if the active lesion is at the edge of a scar, it's suggestive of toxoplasmosis. Now, how do you diagnose ocular tuberculosis? It's a combination of three elements. The first is finding the appropriate clinical signs, some of which we just discussed. The other is finding ancillary evidence in the form of either a Montu test or a quantiferon TB gold test or a chest radiograph. But the most important part is to exclude non-TB entities for the given clinical sign. Together, these three will give you the diagnosis of ocular tuberculosis. We're often concerned about a false positive Montu test in a TB endemic country, but remember, there are several factors that may also lead to a false negative test, especially if it's a faulty technique such as a subcutaneous injection, poor quality tuberculin due to the cold storage not being maintained, disseminated or miliary tuberculosis, or any kind of immunosuppression such as HIV or drug-induced immunosuppression. The last part is getting worried about BCG vaccination and its effect on the tuberculin skin test. Remember, if the BCG vaccination is in infancy, and you know in India it's in the neonatal period, then it hardly has any impact on the results of the Montu test, especially when it is done 10 years or more after the vaccination, which is the case in nearly every patient of ocular TB that comes to you. On the other hand, in the case of TB retinal vasculitis, as you can see in this patient, it may not require corticosteroids all the time, and this one in particular resolved completely in about 4 months without any adjunctive corticosteroids. And finally, what happens if there is recurrence while the patient is on anti-TB therapy? If it's early, less than 1 to 2 months, then remember ruling out paradoxical worsening, an alternative diagnosis test for syphilis and sarcoid. And finally, if both of these are negative, then think of drug resistance as well. On the other hand, if it's a very late recurrence, typically after completion of ATT, once you have ruled out the alternative diagnosis and drug resistance, and if the recurrence is in the form of a non-granulomatous anti-uveitis, just treat it with topical steroids, because such a inflammatory reaction is probably due to the bacterial products alone. There's no need to repeat the anti-TB therapy in these patients. So to summarize again, the diagnostic signs include the subvascular lesions in and the focal vascular tortuosity in TB retinal vasculitis, the multifocal pattern of subpinous-like choroiditis, and the reactivation in the center in tuberculosis. The diagnosis is based on the exclusion of non-TB entities. Remember the possibility of a false negative Montu test and the unnecessary concern about BCG vaccination. In treatment, think of steroids in subpinous, but no steroids in some other forms of ocular TB. And remember, in post-ATT recurrence, it depends whether it's early or a late recurrence. I thank you for your attention.
Thank you, sir. Dr. Anirudh, Partho, sir. Dr. Anirudh?
It's actually, there is some problem in unmuting. Okay, excellent tips. Every time I just go through your talks, sir, I learned so many new things. I have a small question for the benefit of our audience and all. No? So how to interpret a positive or negative Montu test in ophthalmology practice? Like I see many a time the people will do a Montu test, be it a case of anterior uveitis or irrespective of the clinical phenotype. And if the test is positive, they will refer the patient for ATT. So I want your opinion, if you can enlighten us, that how to interpret a positive or negative Montu test in our practice.
Sai, sir is saying, Samya sir, he is unable to mute. Hello.
Come again, madam. Come again, madam. There is some problem in unmuting actually. So he is trying to unmute, but it is saying the host is not allowing you to unmute. So this has happened with me also.
Partho, can you hear me?
Yeah. Yeah, I can hear you. Please.
Yeah, thank you. Finally, I got through. So first of all, wonderful session going on, and congratulations to Dr. Bahunkule and Dr. Shilpi, both of you, for organizing this so well, and Anirudh and Partho for these wonderful questions and the way you have explained the answers to each of them. To answer your question, Partho, I think the point of interpreting a positive or a negative MONTU test has to start with the clear understanding that we are not treating the MONTU test. We are treating the ocular inflammation that is in there. And for that, we need to clearly identify the ocular signs that could be indicative of tuberculosis. This concept is called, it's applied to many conditions in clinical medicine. It's called as pre-test probability. So unless you have a very high pre-test probability of that being TB, your MONTU test or a quantiferon TB gold test is of no value. Now, once you have got those clinical signs that are suggestive of tuberculosis, then you see what is the response to the MONTU, the tuberculin injection in the patient. Now, in TB endemic countries, the cutoff for the tuberculin skin test is 10 millimeters of induration after 48 hours as given by the CDC. Now, if your pre-test probability is higher, okay, suppose it's a HIV positive patient or it's a very close contact of, open pulmonary tuberculosis, then your cutoff for the MONTU could be even lower. So higher is the pre-test probability, lower is your cutoff, which means that in a TB non-endemic country, say in any of the Western countries where there is no TB, and suppose the patient has come to you with a clinical sign that is not suggestive of tuberculosis at all, let's say a VKH or a B27, even if you get a 20 millimeters of MONTU, it has very little value. Similarly, even in the Indian scenario, if your clinical signs are very suggestive of a different clinical entity, then your MONTU doesn't have much value. So please do not use your MONTU test as a screening tool in any patient of uveitis. This is the most important point. The reverse of this is that if you have a clinical sign that is very highly suggestive of tuberculosis, and the most common example of this is a clear multifocal serpiginoid choroiditis, which in a TB endemic country is almost always due to tuberculosis. In this patient, suppose your MONTU test comes out negative, suppose you get a result of 6 millimeter or 8 millimeter, which is below the cutoff limit. Don't start treating with steroids straight away, because your patient will definitely respond to steroids. But when this patient comes back to you after several months or years, you will see that the lesions have actually expanded in size despite the initial response. So you have to chase the diagnosis of TB in this patient. How do you do that? You definitely get the quantiferon TB gold test done, because you need some kind of evidence of TB to start ATT for this patient. You also get a very detailed history of a tuberculosis contact, open tuberculosis contact in this patient. So chase the diagnosis, and most often you will be able to reach the diagnosis of TB in your patient. So both the positive and the negative MONTU test have to be approached in the background of the clinical signs, in the background of the clinical scenario of the patient. I hope that was
yeah, that was very, very important and very helpful. Thank you.
Sai, I think we can unmute everyone.
Yeah, because I'm afraid to unmute myself now because I know it will be difficult to.
Yes, yes. So that we can initiate our next proceedings.
Yeah.
I request everyone to unmute and please, yes, I can see that everyone is, yes.
I hope my last few sentences were heard well because there's some background noise where I am.
Some lag coming, but yes, we could make it out.
Yes. So with this, we are in for the today's quiz session, and we are ready with the winners also. So I request Dr. Samia sir, Dr. Padma Malini ma'am, Dr. Anirudh and Dr. Partho sir, keep open your audios and videos inputs.
Yeah, we are open, Dr. Shilpi. So,
Sai, are you ready with the PPT?
yeah, people, I think, and before we'll finish that team intro.
Yes, sir, we can do that. Sai, just stop sharing your screen. So this is Brain Teasers. It is an effort of a pan-India team. So this is the team which we have. Every time we select few quiz masters from our team, and this team is going on. This is our old video. Without the support from all the members of this gang, it is not possible to conduct the quiz every month. So we are indebted to them, and thank you all of you.
And sing along. Team. When I say team, you say work. Team, 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 team. When I say team, you say work. Team, 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 team. When you're in a team, it's always fun. You know the two heads are better than one. To cooperate is really great. People on your teams are called your teammates. As a group, you can achieve your wildest dreams. Work together because there's no I in team. Doesn't matter who's last and who's first, as long as everybody provides a teamwork. Team, together, everybody, A, team, M. When I say team, you say work. Team, 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 team. When I say team, you say work. Team, 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 when I say team, you say work. Team, 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 team. When we work together, it's teamwork, and that makes things better. When I help you.
So thank you all of you for today's quiz, attending today's quiz and making it a success. So now I request Mr. Sai to please share the screen so that we can announce the results. Yes. So today, as we could see that 2 of the participants, they couldn't join. So there were 5 participants, and naturally all will be eligible for one of or the other prize. So the 5th winner is Dr. Gaurav Majumdar.
Thank you very much. Thank you very much.
Dr. Anirudh, can you just facilitate him with the virtual voucher and just interact with him? Dr. Anirudh?
I think
he's not able to. Okay.
Dr. Gaurav, congratulations. Congratulations on the behalf of this Brain Teaser team. So I'm sure you are very happy.
I am. Thank you so much. Yeah. I'm honored and humbled.
Yeah. Thank you.
So the next winner 4 is Dr. Panchami Gupta. Dr. Panchami?
Yes, ma'am.
Yeah, Dr. Panchami, congratulations.
Thank you so much, sir.
I am sure you must be very happy.
Yes, sir.
Yeah, excellent performance. Congratulations.
Thank you so much, sir.
Assistant performer, and every time she grabs some prize
Oh, great. That's great. Where you are working in Delhi, no?
Yes, sir. Yes, sir.
Rajan Babu TV Hospital.
Yes, sir.
Yeah. Okay, great.
Thank you, sir.
So the third winner is Dr. Nikita Gupta from Chandigarh.
Thank you so much, ma'am. Thank you, sir.
Samia sir, please you can rag her also or anything you want.
No. There is nothing to rag. I think, some of the answers that you guys are giving, I don't know if at your stage of careers, I would have been able to give those answers. So very well done. Just one request to all the winners and all the other participants of this quiz. This quiz was not, only about knowing how much you know, but also about giving away a lot of information. I think the way Partho and Anirudh have really, shaped the whole quiz program. There's a lot of learning in uveitis here, and please try to apply that learning in your clinics. It will be wonderful.
So congratulations, Dr. Nikita. So the second winner for today's session is Dr. Anupama Jayan. Dr. Anupama? I think we again lost her. Dr. Anupama? Yes. Congratulations.
Very well done, Dr. Anupama.
Sir. Thank you, sir.
What are you doing, Dr. Anupama?
I'm now in Kerala Health Service, ma'am.
Okay. Yeah.
Kerala Health Service, government service.
Yes. Okay. Congratulations once again.
Thank you, ma'am.
Finally, the winner is, now everyone must be knowing, that is Dr. Vishnu Deepti Narayanam from Vizag. Dr. Vishnu.
Thank you, ma'am. Thank you.
Dr. Padma Malini, ma'am.
Yeah, congratulations, Dr. Vishnu Deepti. Yeah, very well done. I hope you enjoy this quiz.
Yeah,
Yes.
sure, ma'am. I learned a lot. Thanks.
Yeah, very well done.
So, Dr. Vishnu.
Like Dr. Basu said, both Dr. Partho and Dr. Aniruddha, they didn't conduct like a quiz, and also they given the explanation that it's a good learning curve for all of us to implement these points in a practice.
Yes, ma'am. Sure.
So, Anupama, we can't see you. Yes.
So we congratulate all the winners and also all the participants for their active inputs.
So congratulations to all of you. Thank you, ma'am. Thank you, Samia sir. Thank you, Partho sir. And thank you, Anirudh, for conducting this well.
Many congratulations to everyone.
Thank you all.
So, okay, sir. Thank you.
Congratulations to Dr. Prashant, Dr. Shilpi for facilitating this event at the national level.
Thank you for all the tips.
Thank you, everyone.